Alright, this is the scrubs video for the leg, and this is Ryan Dickerson. I am a British student in class 25, and let's go ahead and get into it. As always, our mission statement for Scrubs is a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Birdie. Members of Scrubs, we participate in a variety of subcommittees, and these are resources created for students by students that offer a unique perspective from students who have gone through these courses before and been exposed to the same challenges that you have faced during this course. The hope is that this organization will become a staple of the Brent student body and exemplify a unique collaborative community that we're hoping to build. If this is something that you're interested in joining, we're always welcoming new members. Now, as a disclaimer, the resources that are included in this document are made by students and not by the faculty, so there is the possibility for errors in our development, although this is mitigated via a team approach with multiple layers of vetting. However, if there's ever a contradiction with the coursework that is being presented by instructors, please go by your main course documents. Additionally, Scrubs is a supplemental resource and not in any way meant to replace the instruction of the Brady faculty. So use these resources as a supplement, and hopefully they'll help you out in your studies. With that, let's go ahead and get into the material, and we're going to start with the osteology of the leg. So starting out, there are a couple of things with the femur that I know we've seen before, but we just want to review. Remember that the femur up in the top has a head and a neck, and then the neck comes down to your greater trochanter, which is located laterally, and lesser trochanter located more medially. In the front, we have an intertrochanteric line. Important that the line is in the front. In the back, intertrochanteric crest. Crest is in the back. C for crack. That is in the posterior aspect of the body, so intertrochanteric crest located posteriorly. Here we see the greater and lesser trochanter. Also posteriorly, we have the gluteal tuberosity. This is, again, remember where our gluteus maximus muscle is inserting. Down in here, we have our linea aspera, origin and insertion for a couple of different muscles. And here is a posterior view of our lesser trochanter, which kind of goes into our pectineal line, where our pectineus muscle is inserting onto the femur. Now, for this video, we really want to focus down here in this inferior region because we're going to be talking about the leg. So we had the adductor tubercle, but I also want to point out that we have condyles. We have a lateral condyle and a medial condyle when we're talking about the femur. And above each one of these condyles is an epicondyle. So we have a lateral epicondyle and a medial epicondyle located here. Okay, here's a posterior view, same thing, lateral condyle, medial condyle, with epicondyles located above. Now, you're going to hear a lot about different muscles originating from the tibia and fibula, so let's go ahead and get those bones down. The first one is the tibia. The tibia is the weight-bearing bone of your lower limb, so your fibula over here is a non-weight-bearing bone. So it's unlikely that you have stress fractures to your fibula. Usually a fibula is going to be broken by direct injury because the tibia is primarily bearing all of the weight. Now, a couple of the bony landmarks, we're going to start proximally, work away distally. Just like the femur, there is a lateral condyle and a medial condyle. So lateral condyle located laterally articulates with the head of the fibula, and then over here we have the medial condyle. And in between, there's an intercondylar eminence. So on top of the medial and lateral condyles, you're going to have the articulating surfaces, and this is where your menisci will sit. So you'll have a medial meniscus, a lateral meniscus. We'll talk about all of that when we do the joints of the lower limb. Anteriorly, we have this bump on the anterior aspect of the tibia. This is the tibial tuberosity. The tibial tuberosity is going to be the insertion point of your patellar tendon, right? So it goes from quadriceps over top of your patella to patellar tendon or patellar ligament, inserting into the tibial tuberosity. Okay, now the tibia and fibula are bound together by an interosseous membrane. This is very similar to the radius and ulna in the upper limb, and this is going to help divide an anterior and posterior compartment. Now, once again, remember tibia, weight-bearing, fibula, non-weight-bearing. Right, now, going down here distally, the two major structures that I want to point out here is that laterally, we have a lateral malleolus, and medially, we have a medial malleolus. And these are similar to like the styloids of the radius and ulna. Now, one thing that I want to point out is that these bony landmarks are going to be super important when we're talking about identifying muscles in lab, because you can identify if a muscle is coming from the anterior, lateral, posterior compartment, based on their orientation to the malleoluses. So that's always the first thing I look at when I'm looking for identification of muscles in lab is, does this tendon pass anterior to the medial malleolus or posterior to medial malleolus? And I'll do the same with the lateral malleolus as well. And that'll help me define the compartment that the muscle comes from, which limits my answer choices down to at most 3. So before we go into the actual identification of the muscles, let's talk about the fascia of the leg. So up here in the thigh, we have the fascia lata of the leg, but as we come inferiorly, that's going to change names into the deep fascia or the crural fascia. And the crural fascia is really just a continuation of the fascia lata, and it's going to divide the lower limb, which we refer to as the leg, into different compartments. So we're going to have an anterior compartment, a medial compartment, and a posterior compartment. And we're going to break down each one of these compartments into the muscles that are located there in just a moment. Now, the big thing I want to point out is that each of these compartments has a major nerve that is associated, and we're going to cover that in more detail. And then the posterior compartment is actually divided into a superficial and deep layer, which we'll cover on 2 separate slides, and that's separated by the transverse intramuscular septum. So the big thing here is you can actually see that there is a potential for a cross-section to be given and the need for you to determine the muscle. And you can do this by defining what compartment you're in and then what muscles could possibly be there. So in this view, we'll talk about this more later, is we see 2 bones. That's going to tell me that I'm in the lower leg I'm in the leg as opposed to the thigh up here where we have 1 bone, the femur. And then I have to say, anterior compartment, lateral compartment, posterior compartment with a transverse intramuscular septum. And then from there, once we talk about these muscles, we'll be able to identify the muscles, and then because there's a major nerve associated with each compartment, the different nerves that are associated as well, just by knowing what compartment we're in. We'll cover this towards the end of the video. Really quickly, I want to talk about the retinacula of the ankle. It's important to note that just like in the wrist, we need to have retinacula that are going to keep our tendons from bowstringing. So by having these retinacula, we have the muscles coming down with our tendons running underneath. When we have contraction, we're going to have contraction along where these tendons are running. If we did not have these retinacula, it would instead come up and we would have just contraction, and we would have the insertion coming up to the origin kind of in this angle as opposed to running up. So the retinacula are super important. Right here we have a superior extensor retinacula tying everything down, and then we have an inferior extensor retinacula of the foot, and this kind of makes a Y shape as it's coming across the foot. All right, and then here's the fibular retinacula, because this is the lateral malleolus located right here. Going behind the lateral malleolus, we're going to see the tendons of our fibularis brevis and longus, which we'll cover in just a moment. But important landmarks is that these are going posterior to the lateral malleolus, whereas these tendons are going anterior, and that helps in the identification of the compartments of the leg. Now, before we get into the compartments of the leg, we have another fossa. And just like anything else, this has borders, and it's going to be important for you to know the borders and the structures that are running through this region, as well as how to identify in lab. So let's start with the borders of the popliteal fossa, which is better seen in this image on the right. The superior lateral border, so important that we're talking about lateral, is going to be this border here. This is going to be the biceps femoris. So the biceps femoris, remember, that runs laterally, whereas the semimembranous and semitendinous run medially. And I remember this by semimembranous with an M, running medially. So superior lateral border, biceps femoris tendon. Superior medial border is going to be the tendons of the semimembranous and semitendinosus. Coming over here. Now your inferior lateral and inferior medial border are the 2 heads of your gastroc muscle. Gastroc muscle is this large muscle in the posterior aspect of the leg, which we'll cover in more detail in a moment. But here is your inferior borders. Now, the floor of your popliteal fossa, that's going to be formed by the popliteus muscle, which you can't really see here. It's better seen on this image. Here's your popliteus muscle, kind of in the base of your popliteal fossa. All right, and then of course the roof is going to be the skin that's overlying this region. Now, what I want to point out is that it is important that you know the structures that are superficial to deep in this region. The most superficial structure in the popliteal fossa is going to be the nerve. So this is your sciatic nerve, which is made up of your tibial and common fibular nerve. So here we go here, the tibial and common fibular nerve. And you see kind of in this view we're actually seeing the tibial nerve coming down and the common fibular nerve split off, running around towards the head of the fibula, which we'll talk about in a little bit more detail. But you can see that in both images, where the sciatic nerve is coming down and splitting. I'm really showing the difference between the tibial nerve and the common fibular nerve. So that's most superficial. The next structure we see in the popliteal fossa is going to be the vein, as we're going deep. This is your popliteal vein. Remember that this used to be the femoral vein as well as the femoral artery, but they changed names when they go through the adductor hiatus, which enters into the popliteal fossa. So here we go, popliteal vein, and you'll see that the popliteal vein gives off a vein, or has a vein running into it, called the small saphenous vein. The small saphenous vein runs directly down behind the gastroc, and it's actually going to come on the lateral compartment, or the lateral region, I should say, of the foot, and it's going to help drain from the dorsal venous arch up into the popliteal fossa. So vein coming back to the heart, draining this way, draining into the popliteal fossa from superficial to deep. Lastly, we have our popliteal artery, which is at the floor of the popliteal fossa. This is one that you'll palpate for checking for pulses, and it's important that we know that the popliteal artery actually has some branches coming off, which we'll cover in more detail later on. But we have on either side medial and lateral superior genicular arteries. Genu refers to the term bend, so of course our knee has a bend in it. So we're going to have a superior genicular artery that's on the medial aspect, one on the lateral aspect, and then we have inferior genicular arteries coming down here. So there's your inferior genicular arteries, and then we have one medial, which is going to be, should be here. It's just on the medial aspect of the leg. And again, covering this in more detail a little bit later. And then just one more time, overview the borders of the popliteal fossa, because you're likely to get tested. Superior laterally, the biceps femoris. Superomedially, the tendons of the semitendinosus and the semimembranous muscles. Inferior medial and inferior lateral, you have the different heads of the gastroc. On the floor, you have the popliteus muscle. And then in the contents that are within, popliteal vein, popliteal artery, and their associated branches. The sciatic nerve coming down into the tibial nerve, giving off its branches, and then the common fibular nerve coming around the lateral head of the fibula. One thing that I do want to point out, we'll cover this more with nerves, is you kind of start to see this forming, but the tibial nerve, as it's running down, is going to give off a small branch superficially that's going to end up running along with a small saphenous vein. And the common fibular nerve is doing the same. It's giving off the small branch here. Eventually, these two branches will come together and run with a small saphenous vein, and these will be called the sural nerve. And that is a cutaneous nerve to the posterior aspect of the leg. So we'll see this again. Just want to point that out so you keep it in mind. Now, getting into the muscles, the next couple slides are just going to dive into the muscles, their origins, insertions, nerves, and actions. So big thing here is the muscles of the anterior leg. These are all going to pass anterior to the medial and lateral malleoluses. So they go anterior to the malleolus. So if you see a tendon and you know it goes anterior to the malleoluses, you know that it is from the anterior compartment of the leg. And once I know it's from the anterior compartment of the leg, I can only have 4 possible answers if I'm identifying all of these muscles in the anterior compartment. So each compartment, once again, has an associated nerve. And if I know what compartment it is, then I know the nerve is innervating these muscles. So all of these muscles are innervated by the deep fibular nerve, L4 through S2. And all of these nerves, but the fibularis tertis, which has a little special part, are going to be, are going to assist in inversion of the foot. So fibularis tertis is the only one that, in the anterior compartment, that does not assist in inversion. So everything else inverts the foot as one of its partial actions. So let's start medially and work our way laterally. First, we have the biggest muscle in the anterior compartment. This is my tibialis anterior. Great, this is my anterior compartment, and it's right associated with the tibia. Perfect name, tibialis anterior. So it's originating from the lateral surface of the tibia, and it's inserting onto the medial cuneiform and first metatarsal. So it's actually going to come down through the anterior aspect of the foot, passing anterior to the malleoluses, and it's going to wrap around and insert into the medial cuneiform, which is located right in this region, and the first metatarsal. So that's your tibialis anterior. It is going to dorsiflex, so bringing your toes closer to your shin, and invert the foot. Okay, make sure we know inversion versus eversion when we're talking about actions on the ankle. And again, all of these muscles innervated by a deep fibular nerve, L4 through S2. The deep fibular nerve, if you recall, is a branch of the common fibular nerve, and it specifically is going to supply all the muscles in the anterior compartment of the leg. Next, we have the extensor digitorum longus. The extensor digitorum longus is located just beside the tibialis anterior, and it is going to arise from the proximal surface of the fibula and the interosseous membrane, and it's coming down, and as it comes down, again, going anterior to the malleolus, it's going to insert into the middle and distal phalanges of digits 2 through 5, and this is going to form the extensor expansions, just like you had the extensor expansions in the fingers. And again, innervated by the deep fibular nerve, L4 through S2, and this action is going to be to extend the toes and dorsiflex the foot. Next, the extensor hallucis longus. This is actually come down a little bit further because it doesn't originate from as high up. So originate from the middle aspect of the fibula, and the interosseous membrane, and it's going to go to the distal phalanx of the big toe, doing exactly what it said, the hallus, which refers to the big toe. So extensor hallucis longus, coming down in purple here, going towards the big toe, innervated by the fibular nerve, as all of these muscles are, and it's going to extend the big toe and help dorsiflex. Remember, all of these muscles here also have, to some degree, a component of inversion. Next, we have our special muscle, the fibularis tertis. Fibularis tertis is sometimes hard to identify, but it's actually a small part of the extensor digitorum, or extensor digitorum longus, and it's arising from the extensor digitorum longus, kind of in this region, and then it's going to come down across the foot, maybe this tendon here, and it's going to insert into the base of the fifth metatarsal. So the tertis is going to be special for a couple regions, but the fibularis tertis, arising from the extensor digitorum longus and the distal fibula, coming around, inserting into the fifth metatarsal, and innervated by the deep fibular nerve, it's going to have dorsiflexion. And here we have eversion. So it's a special muscle of the anterior leg. It actually assists in eversion of the foot, and you'll see that that's a common trend for all fibularis muscles. The fibularis tertis, anterior compartment, eversion, innervated by the deep fibular nerve. Now moving to the lateral leg. The lateral leg just has two muscles. Great, and they both have fibularis in their name. So these muscles pass posterior to the lateral malleolus. Okay, we can see that down here in this image. They're passing posterior to the lateral malleolus, which is located here, and that is going to define these muscles. They're passing posterior to the lateral malleolus. You have the fibularis longus and fibularis fibularis longus and fibularis brevis. Look at the malleolus. I'll say this over and over again, but that's so important when you're identifying these muscles in lab. So the fibularis longus is going to originate from the proximal part of the fibula, and it's going to come down, and it's actually crossing the sole. You can see that here. It's going to cross the sole. Fibularis longus tendon crossing the sole, so that way it can insert into the medial cuneiform first metatarsal. Why is that important? Because if it crosses the sole, imagine contraction of this muscle. It contracts, and it's going to bring the medial part of the sole laterally, and that's going to cause it to evert the foot with an E, eversion of the foot. So really important that we know that it's going to cross the sole, inserting onto the medial cuneiform first metatarsal to evert the foot. Next, we have our fibularis brevis, originating from the distal part of the fibula, so just a little bit further down, and then it's going to insert into the fifth metatarsal along with the fibularis tertis, which we saw coming from the anterior compartment in the previous image, and it's going to evert and plantar flex the foot. So both of these muscles are going to evert and plantar flex the foot. We're just better at doing that, the fibularis longus, than the brevis. Now, both of these muscles, again, each compartment has a nerve associated. The nerve associated with the lateral compartment of the leg is going to be your superficial fibular nerve. Superficial fibular nerve. So both of these muscles innervated by the superficial fibular nerve. Okay, so the two muscles of the lateral compartment of the leg, fibularis longus, fibularis brevis, both innervated by the superficial fibular nerve, L4 through S2, and they both are going to evert and plantar flex the foot. Now as we go into the posterior part of the leg, remember that the posterior aspect of the leg has two subcomponents. There is a superficial compartment and a deeper compartment. So we're going to start with the superficial compartment, which is going to have three muscles. All these muscles are going to insert onto a common tendon, a calcaneal tendon, also known as Achilles tendon. We're going to use calcaneal tendon in anatomy because it's going to insert onto the calcaneus, which is the bone at the back of the heel. All of these muscles in the posterior compartment of the leg. This will be posterior leg, the superficial and the deep, but all of them are going to be innervated by the tibial nerve L4 through S3. Okay, tibial nerve. So we're going to start with the gastroc. The gastroc has been cut here, but remember you saw in a previous image it had the two heads. There's a medial head, a lateral head that come down, and they're going to insert into the Achilles tendon. This is the primary plantar flexor of the foot, so causing plantar flexion. It also has a little bit of knee flexion when the knee is not weighted, and that's because it's actually crossing the knee joint here. Next, we have the soleus. The soleus is muscle in green. The soleus has an interesting origin on the tibia and fibula. Coming kind of from lateral to medial. It's going to come down and it's going to again insert into the Achilles tendon. And this is one of the this muscle here is one of the muscles that allows for long distance running. It has a very unique ability to conserve energy and to operate over a long amount of time, whereas your gastroc is more of a power muscle for a short, quick burst. And then tibial nerve, again, L4 through S3, as all these muscles will be. And plantar flexion is the primary mechanism here. Next, we have the extensor hallucis longus. Oh, sorry, that should not say extensor hallucis longus. That should be the plantaris muscle. Ignore that. The plantaris muscle is originating from the lateral supracondylar line, and it is coming down to the calcaneal tendon, right? And it's going to have plantar flexion and weak knee flexion because it does cross the knee joint. So ignore this here. It is not extensor hallucis longus. It should be the plantaris muscle coming from lateral down to medial. It has a very long tendon, very easy to identify in lab, but because it does cross the knee joint, it can have some weak knee flexion as well. Next, we're going to do muscles of the deep leg. I think here's where it gets a little bit more tricky. Usually this is where students struggle, but we're going to make it straightforward. Again, everything here innervated by the tibial nerve, L4 through S3, and that's because it's located in the posterior compartment of the leg. All of these muscles, if they cross the ankle joint, are going to cross posterior to the medial malleolus. You're going to see that's really important. We now have a compartment that passes anterior to both malleoluses, maybe. Then you have a compartment that passes posterior to the lateral malleolus, and now you have a compartment that is sending tendons passing posterior to the medial malleolus, and this is going to be the posterior deep compartment of the leg. So the first muscle we're going to talk about is the only one that does not cross the ankle joint, and that's the popliteus muscle. So popliteus muscle coming here. You see that it's coming from lateral to medial. So it's going to originate from the lateral condyle and lateral meniscus, and it's going to insert into the posterior aspect of the tibia, which is located medially. Now, all of these muscles, once again, innervated by the tibial nerve, L4 through S3. The action of this muscle is to unlock the knee. So you actually have to have a little bit of twisting motion at the knee in order for you to have flexion. And that's the function of the popliteus muscle. And this also has some very weak flexion of the knee as well. Now, we're getting into the muscles that cross the ankle joint. The first one, flexor digitorum longus, located here in green. The flexor digitorum longus is going to arise from the medial aspect of the tibia, and it's going to insert onto the distal phalanges of digits 2 through 5, flexor digitorum longus. Okay. Again, innervated by the tibial nerve, like all of these muscles, and it's going to cause flexion of the distal interphalangeal joints, and then plantar flexion. Okay, so just like in the hand, the flexor digitorum longus is going to go all the way to the distal phalanges. Okay, distal phalanges. Next up, we have the tibialis posterior. Tibialis posterior coming down, wrapping around behind the medial malleolus, and it's going to arise from the interosseous membrane, the tibia and the fibula, and inserting onto the navicular, cuneiform, cuboid, and second through fourth metatarsal. So a lot of the structures in the foot. It's going to be innervated, again, by the tibial nerve, L4 through S3. We'll keep on saying it. Everything in the posterior compartment of the leg, innervated by the tibial nerve, L4 through S3. Action of this muscle is going to be inversion. Just like the tibialis anterior, both the tibialis muscles cause inversion of the foot. And then the tibialis posterior is going to have plantar flexion, whereas the tibialis anterior had the dorsiflexion. Next, we have our flexor hallucis longus. This is the last muscle of the deep compartment of the leg. The flexor hallucis longus is coming down and around, again, posterior to the medial malleolus. It is arising from the fibula and the interosseous membrane, and it's going hallucis to the distal hallux. Okay, so the distal large toe. And it is going to flex the toe, and it's a very powerful push-off muscle for sprints. Okay, so once again, muscles of the posterior leg, deep compartment, all innervated by the tibial nerve, because it's in the posterior compartment, and the tibial nerve is associated with the posterior compartment of the leg. They're all passing posterior to the medial malleolus if they're crossing the ankle joint, right? So really important features there. Again, look at the malleolus. It's so important. Right here, we're looking at a medial aspect, big toe, of the ankle. Here is the medial malleolus. Calcaneal tendon come down into our calcaneus. We know all of these muscles here that are inserting are part of your superficial compartment. That tells me that it's the gastroc, the soleus, the plantaris muscle. Now I'm looking at these tendons that cross the ankle joint, going posterior to the medial malleolus. I know that the only things that this can be is the tibialis posterior, the flexor digitorum longus, and flexor hallucis longus. Now, I do want to point out, there is a mnemonic for identifying these tendons just based off the tendon alone. I can't see the muscle bellies. I might have trouble identifying it. But what do I do in lab if I get this question? Well, as we're crossing the ankle joint, there's a very specific orientation. We're going to have a mnemonic, Tom, Dick, and a very nervous Harry. So, Tom, the T, that stands for tibialis posterior. This is the most anterior muscle tendon that comes through. So, tibialis posterior. Next, Dick, we have the flexor digitorum longus. Okay, D for digitorum. The A very nervous refers to a neurovascular bundle that actually comes in between the flexor digitorum longus and the flexor hallucis longus. You're going to have the posterior tibial nerve and the posterior tibial artery and tibial nerve running down in this region. So artery, vein, nerve. So artery is anterior, nerve is posterior, and then lastly, you have the flexor hallucis longus coming down, going all the way to the big toe. So remember Tom, Dick, and a very nervous Harry. We are trying to identify the structures from anterior to posterior in relation to the medial malleolus. Now let's get into some innervation of the leg. There are two major nerves that are innervating the leg. They are both coming from the sciatic nerve. Remember, the sciatic nerve is really combined of your tibial nerve and your common fibular nerve. Now, your common fibular nerve, it comes down off the back of the leg, and it wraps around the head of the fibula. So there's a fibular head there. It comes down laterally, wraps around the head of the fibula, and look at here. Now it's in the anterior and lateral aspects of the leg. It's going to give off a superficial branch and a deep branch. The superficial branch is going to stay in the lateral compartment of the leg, whereas the deep branch comes a little bit more medially to get into the anterior compartment. And that's why we have the superficial fibular nerve innervating the lateral compartment of the leg, and the deep fibular nerve innervating the anterior compartment of the leg. You're going to see that the deep fibular nerve is going to come down. It will actually come down into the dorsal aspect of the foot. Next, over here in the back, we have our tibial nerve. Our tibial nerve comes down. It's going to give off all its branches, but it's going to stay as a tibial nerve, innervating all the musculature. And then as you get down to the foot, you're going to have a medial plantar and lateral plantar nerve. Okay, so big things here is sciatic nerve coming down. You have the common fibular nerve wrapping around the head of the fibula. It gives off a deep fibular nerve and a superficial fibular nerve, whereas the tibial nerve just runs all the way down, and then once it gets behind the medial malleolus, it's going to give off a lateral and medial plantar nerve. So continuing a little bit with the innervation of the foot, I do want to talk about some of the cutaneous supply. The innervation of the leg. As we're coming down, I already mentioned this, but here goes the sciatic nerve, being composed of the common fibular, also known as the peroneal nerve, if you ever see that. They're referring to the same thing. The common fibular nerve coming around the medial malleolus, the fibular head, and then the tibial nerve coming down. They both give off a component right here that forms the sural nerve. So the sural nerve is a cutaneous nerve that runs around the back posterior aspect of the leg, behind the lateral malleolus, and towards the lateral aspect of the foot. And this is going with the small saphenous vein, which dives in and drains into the popliteal vein, which we saw previously. So I pair these two things together, nerve and vein running together, going behind the medial malleolus to the lateral aspect of the foot. And this is made of components of both the common fibular nerve and the tibial nerve. both giving components to the sterile nerve. Okay, and then over here, other cutaneous branches I want to keep in mind. The great saphenous vein is coming down around the medial aspect of the foot, and then right when you come out of the adductor canal, you also have the saphenous nerve that's supplying the medial aspect. So the saphenous nerve and great saphenous vein are running together in this region, supplying the medial aspects of the leg, coming down to the medial aspect of the foot. Right, and here we can see this in a more anatomical view. Same thing, common fibular nerve going around the head of the fibula, giving off a superficial branch and a deep branch, which are going to supply both the lateral compartments, that's the superficial fibular nerve, and the deep compartment supplied by the deep fibular nerve. And if you want to pair arteries and nerves, know that the deep fibular nerve is running with the anterior tibial artery. Okay, just running right on down to the dorsum of the foot. Speaking of arteries of the leg, let's go ahead and knock some of this out. We mentioned the popliteal region already, but let's see it again. We have the femoral artery coming down through the adductor hiatus, and then it becomes a popliteal artery. Popliteal artery is the deepest structure in the popliteal fossa. As it's coming down, it's going to give off a couple of genicular arteries. We have superior genicular arteries that come on both the medial and lateral sides. Then we have a middle genicular artery coming off here. Then we have the inferior genicular arteries coming off on the end. So really, you're just going to identify this based off the region in the popliteal fossa. Is it superior or is it inferior? You have some circumflex fibular arteries. I don't think these are as important to know. We're going to talk mainly about the main branches. That being, as we come down the popliteal artery, we are going to get bifurcation into the posterior tibial and anterior tibial artery. The anterior tibial artery is going through the interosseous membrane into the anterior compartment of the leg. Posterior tibial continues to come down. As it's coming down, it's going to give off a branch, the fibular artery. The fibular artery is going to run laterally in the posterior aspect of the leg down to the lateral malleolus, whereas the posterior tibial artery continues down to posterior of the leg, and it's going to run behind the medial malleolus. Okay, so as we're following the femoral artery down, femoral artery becomes popliteal artery, gives off its genicular branches, just meaning that they're going around the knee. It's going to give off a branch called the anterior tibial artery, which runs into the anterior compartment of the leg through the interosseous membrane. Posterior tibial artery continues inferiorly. It gives off a fibular artery, which runs laterally, still in the posterior compartment, and then the posterior tibial artery continues behind the medial malleolus at the ankle. Here we have an anterior view. Here you see your fibular artery going through the adductor canal, goes to the adductor hiatus, it's behind the knee as a popliteal artery. It's doing all of its genicular branches, which we actually see here in the front. And then there it goes. There's a bifurcation giving off the anterior tibial artery through the interosseous membrane. So now we're going to follow the anterior tibial artery. Anterior tibial artery comes down, 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 down. And as it gets across the ankle, it's going to change names to the dorsalis pedis artery. This is one of the vessels that you palpate when you're checking for distal pulses. So it comes right over top of the ankle, and it's actually going to dive between the first two toes. So that is your dorsalis pedis artery. And again, remember that the anterior tibial artery is running with what nerve? You got it. It's running with the deep fibular nerve. So same pathway, deep fibular nerve, anterior tibial artery coming down, and then eventually they're both going to cross into the foot and dive in between the toes. We mentioned this in passing, but I just want to point out the veins of the leg. When we're talking about the veins of the leg, I really think about medial and lateral sides. On the medial aspect of the foot, foot and leg, we have this vessel coming up all the way up to the thigh. This is going to be our great saphenous vein. And remember the great saphenous vein, after you cross the knee, you have the saphenous nerve running with it, which is a cutaneous nerve innervating this region of the leg as well, cutaneously. So it's coming down, and it's going to contribute to our dorsal venous arch up in here, and then it comes up, and it's going to drain into the saphenous vein and through the saphenous opening all the way up in the femoral triangle. Now here we have the sural nerve, the small saphenous vein, which runs with the sural nerve coming from the lateral aspect. Again, went behind the lateral malleolus to the lateral aspect of the foot, drains up, and it's going to end up draining in the popliteal fossa into the popliteal vein, which will then drain up. And again, that's going to turn into your femoral vein, and that's going to keep on going all the way up into your external iliac, common iliac, and then it's going to get into your inferior vena cava. Okay, and that gives you the veins of the leg. Now, again, I mentioned this as a preview earlier, but you will be asked questions about cross sections, and you need to be able to remember that every cross section in the leg is going to have a different compartment, and each compartment has a different artery or nerve that is associated. So if I can identify the compartment of the leg, then I can go ahead and identify the muscles that should be there, as well as the innervation and vascular supply, and that's going to help me identify these on a cross section very easily. So how do I do this? Well, we'll see this more in the next slide. I'll give you a preview. I see two bones. I see a larger bone and a smaller bone. That's where I start. Tibia, fibula. Okay, so I go from there. Next, I look, is there anything that has different compartments, like a superficial compartment and a deep compartment? I say, sure. Look back here. I have 3 muscles located superficially, then have a deeper compartment. This is going to help me identify this is the posterior aspect of the leg. If I don't like that, that's fine too. I can look in the back. Is there anything with a nerve and vein combo? Well, I don't have anything in the anterior cutaneous aspect of the leg, but I do have a sural nerve and a small saphenous vein located posteriorly. And then remember that I have a vein located kind of the medial aspect of my leg, the great saphenous vein. So again, I can identify this as the posterior aspects. So a couple of different ways we could have done that. But now once I have that identified, I say, oh, if this is posterior, then this must be the posterior compartment. And then anterior compartment. And what do you know? Lateral compartment over near the fibula. Well, the lateral compartment has a nerve with it. What do I remember that nerve being? Lateral compartment of the leg, musculature, innervated by, oh, that's right, the superficial fibular nerve. And there it goes there. And then the anterior compartment, also associated with a nerve. This nerve, the deep fibular nerve. What artery runs with the deep fibular nerve? You got it, anterior tibial nerve. Okay, well, great, but the posterior compartment, I mean, it's got a nerve. Oh, the tibial nerve. Right, I remember that, but there's 2 vessels. How do I do that? Well, I don't understand. I know there's a posterior tibial artery, but what else do I do? Well, posterior tibial artery is giving off a branch in the posterior aspect of the leg called the fibular artery. How do I identify which is which? Which one is closer to the fibula? That's right, the fibular artery located right here. Which one is closer to the tibia? Bam, you got it. Okay, so this is how I'm going to break down cross sections of the leg. I'm going to look at the bones. I'm going to see, is there 1 bone or is there 2 bones? If there's 1 bone, I'm in the thigh. If there's 2 bones, then I'm in the leg. Next, I need to define my compartments: anterior, lateral, posterior. Once I've identified my compartments, that's all I need to do. I know the nerves that are associated with each compartment. I know the arteries that are associated with each compartment. And once I've got that, it's going to be easy going. And then you'll just have to be, well, I'll say easy going. Then you still need to know how to identify the muscles in those compartments. But I think the main thing is if you can identify the compartment, the nerves, the vessels, based on the compartment you're in good shape. So this is just another view of the algorithm of how to approach this. First thing you ask, what are the bones? Where's the tibia? Where's the fibula? Tibia, big bone. Fibula, small bone. Next, how do I determine anterior versus posterior? 2 ways to do this. I can see that there's a septum coming across. That will tell me this is posterior, this is anterior. Or I can say, hey, look back here. There's a vein in the back with a nerve. This is my small saphenous vein and sural nerve telling me this is posterior aspect. Next, what is lateral? What is medial? Well, the tibia is going to be on the medial side. Fibula going to be on the lateral side. So medial, lateral. And now we've also determined anterior, posterior. Well, that means this must be the anterior compartment, lateral compartment, posterior compartment, with this being superficial, this being deep. What artery runs through the anterior compartment? Anterior tibial artery. What nerve? Deep fibular nerve. Got it. What nerve runs through the lateral compartment? Well, you got this. This is superficial fibular nerve. Going in the back, okay, I've got 2 arteries here and 1 nerve. That nerve, posterior, this is going to be the tibial artery, right in the posterior compartment. And then here we know that there's a fibular and posterior tibial artery. Which is which? Well, associated with the fibula, bam, fibular artery. Associated with the tibia, you got it, tibial artery. Okay, so that's, again, just how you break down looking through cross sections when you're in the leg. Now we're going to finish up with some clinical anatomy. Okay, we'll keep the clinical anatomy relatively short. The first thing we're going to talk about is the calcaneal tendon rupture, also known as the Achilles tendon rupture. These tendons, you'll see this with the ACL and PCL, are highly vascular. So when they are damaged, you get a lot of swelling, which you can see here. There are 2 tests that are being shown here. One is the Thompson's test, or the squeeze test. You take the gastroc and the soleus, and you squeeze them in your hands. And what you're doing is you're causing artificial contraction. What should happen when you contract if the tendon is intact, when you contract the soleus and gastroc, you should see the toes move downward. kind of like this here, toes moving down. If this doesn't happen and there's a rupture, then you will get no movement of the foot, which is a positive Thompson's test, meaning that there is a calcaneal tendon rupture. In this view, we're seeing that there's not even any forces being applied, but we know that there is damage to this tendon. Why? Because we can see the tendon here, nice and clear, and because it's giving plantar flexion just at base, we see the toes pointed downwards. But if we end up rupturing this tendon and there's no counterforce, then all the muscles in the anterior compartment are unopposed, and then we get the more dorsiflexion. So even just laying on the edge of the table, we can see that one of these ankles is much more dorsiflexed than the other. This one over here on the left, and this is going to represent a calcaneal tendon rupture. Last thing we're going to talk about is the common fibular nerve injury. Now this is important. We said that the common fibular nerve is coming through with the sciatic nerve into the posterior aspect of the thigh, but then it wraps around the head of the fibula. And because it wraps around the head of the fibula, it's in really close association with that bone, and it makes it really prone to injury. It's kind of like the ulnar nerve in the upper arm. When it's wrapped around that bone so tightly, it's very superficial, and it's the most likely nerve to get injured in this region. So how does this present? Well, common fibular nerve injury is going to give loss to deep fibular nerve and superficial fibular nerve. But usually the presentation that you notice is going to be due to the deep fibular nerve loss. This means you're going to lose all of the dorsiflexors of the foot. You lose the tibialis anterior, you lose the extensor digitorum longus, you lose the extensor hallucis longus, which all were crossing the ankle joint and causing dorsiflexion. Without this, I now get what's called foot drop. So you tell a patient lift their foot up, and you ask them to dorsiflex, and if they cannot, if instead of their foot coming up like this, it drops down, that is positive for foot drop. You may see someone walking, and they're talking about their toes are dragging on the ground because they're having to lift up what we call steepage gait. They're having to lift their knees up really high in order to get their foot off the ground, and that's because they don't have that dorsiflexion. Okay, so it can cause an altered gait. Another way that this can occur, so how do I even damage the fibular nerve, is what we call a Mason-News fracture. Mason-News fracture is caused by a high ankle sprain. It's a fracture that causes fracturing at two locations because the interosseous membrane and the different ligaments kind of make this like a hula hoop, where if you break at one point, you often break at another. And a common point of weakness is down here on the fibula, and you could have the common fibular nerve running around and getting damaged here. So big presentation of common fibular nerve injury is due to the loss of the deep fibular nerve, which is going to be foot drop. So that's your main takeaway here. And with that brings us to an end of this video.